Hello, everyone, and welcome to another edition of the Empowered Patient Podcast, where medical disruptors, insiders, patient advocates, and more come together to improve healthcare, particularly for cancer patients. So welcome. I cannot believe I have Dr. E on my podcast. I've been so excited about this. And as you all probably know from social media, she's Dr. E, the NP with a PhD. And this woman knows her stuff. I am so impressed by all of the material that she's putting out. And as I had mentioned before, she really has made a big difference to a lot of people. And I just cannot tell you how excited I am to have her here. Welcome.
Thank you. Thank you. What a nice introduction to say I have impact on people. That's my entire purpose in life. Thank you.
Of course. So, just as a starter, why don't you just tell me a little bit about your journey and how you got to be where you are as Dr. E, because I think that's very interesting.
Thank you. And I think it's important also for our audience to know who's speaking, right?
Yeah.
Because there's a lot going on in the world.
Yeah.
So I am a nurse practitioner, family nurse practitioner, board certified, and I opened up a primary care practice 11 years ago, serving the entire family. And it was just traditional, conventional medicine, still is. We serve over 20,000 patients, pediatric, adult, house calls with an angle to LGBT community and the Black and Brown community. And, practice, just think primary care. That's what we are. And around the same time, my wife got sick, and we could talk more about that later.
Mm-hmm.
And then I realized we needed a little bit more. I'm in medicine, she's in medicine, but medicine didn't really help us. And so from the space from within, with as much, scientific inquiry as possible, we ended up finding ourselves kind of on the dark side. And although it's quite
I love when you say that. That's so funny.
And it cured her, absolutely cured her. And I was like, what the heck is this? This is not anything we learned in school. It's not anything the journals talked about. Up to date didn't discuss it.
Sure.
And so then I went all in, took another course, got certified in functional medicine, got a PhD in integrative medicine, and then started teaching people, working with people differently. But all of it, really importantly, is very much based on evidence-based medicine with another layer.
Mm-hmm.
And so I think it's important to have your feet in both worlds.
Oh, I completely agree, which is one of the reasons I have you here. We've had this conversation before. Maybe you and I can help make the link to the rest of the world, because where I come from, there isn't a lot of functional medicine that's included in our treatments for cancer. And I know, just from an empowerment statement part, that patients really thrive and desire to have that aspect, because those are things that they can change.
Yeah.
Whereas the chemo that I give them is just, I'm just treating them. But the things that you talk to them about really can make a difference for them.
And it's a spectrum, right? Because certainly we couldn't do anything without what you do either, right? There'd be no patient. So, when we're looking at illness, there's a spectrum.
Right.
We have wellness on one side, illness on the other. Wellness is I've never felt better. Illness is they're coming to you for chemo or any illness. But there's a whole world from wellness to illness where you're not diagnosed. You can go to the doctor over and over again and be told you're fine. Your annuals are great, but you're not feeling fine. And so your world starts from that illness point on.
Absolutely.
And we need it. But it has zero tools for up until that diagnosis. No tools at all. And I think
even after the treatment.
Right. So we treat amazing. And now we're kind of back to this non-illness state. But I'm certainly not well. And how do I prevent myself from getting ill? There's no tools there. And so I think what's missing in medicine, medicine is perfect the way it is, with the fact that it just needs slightly less hubris, where a provider can say, listen, I did what I could with my tools. Here's a whole list of other providers that can help you with this other piece that I can't, as opposed to saying that stuff's nonsense.
Right.
That's where it all falls apart.
Right. Well, I think some of it is also because that most of the doctors in allopathic medicine are not educated in the functional world and are not necessarily reading the same articles that you are, because we're focused on the treatment, not on the prevention and the aftermath, right?
Yes, that's true. And So in one of my speeches, I talk about how we got here, and it's a certain amount of indoctrination. And indoctrination means, right, we associate it with fanaticism, where we teach the one true religion. And not only do we teach the one true religion, but we teach that all other religions are false and dangerous.
Mm-hmm.
And that's the part that is a bit inexcusable with all that we know. So medicine can teach the medicine. That's great. The problem is the part that says, if you don't subscribe to these protocols, if you use any other type of evidence that we have not stamped, it is dangerous.
Mm-hmm.
It is quackery. And it's not good. And that's the piece. Like, why can't they just teach, like, this is a great set of tools once your patient is sick. We don't teach this other part, but this part still exists. And if we could just add that one sentence,
right,
it would make all the difference.
Give it some validity. Sure.
Yeah. And then stop calling it alternative.
I'm calling it functional. How do you like?
No, yeah.
Is that a good term? No, really. I mean, it's sort of like when you're talking about an African American, or you call them a Black patient, or you call it. It's like, what are the right words? What is the right way to call a patient with dark skin? What is the right thing to call the type of medicine that you are practicing?
It's a great question, but I would say, going back to that same example, it is the fact that we're still in a place where when we say patient, we don't say white patient, we say Black patient, to let us know that default is white.
I say white patient.
Oh, well, maybe you do, because in medicine we tend to write that.
Okay. Well, because that's the only place I would use it. I mean, it's part of your description.
It's true. Right? I would say primarily in language, we tend to delineate what we consider by default other.
Okay.
And I think that's what happens here, whether you call it alternative, functional, holistic, it's other than conventional.
Right.
And I find that annoying. I don't know what to call it, but I'm just saying I want us to expand our mind. I call it functional also by default. But what I'm saying is just the fact that we have everything else has a title, as opposed to even conventional medicine doesn't sound right, because it's like medicine. It's medicine.
That's why I always use allopathic, because I feel like that's,
Yeah, allopathic.
Wow.
Yeah. So, I was on a podcast with a lawyer. She is a lawyer to help people in this kind of alternative landscape and functional landscape, because there's this whole world of, the protocol. We're following the protocol. And I said to her, why is like the onus on the holistic side? Why isn't there also onus on the conventional side? Because there's a lot of harm that's being done by, for example, I think we're going to get to this, telling people with cancer that they could eat sugar. Or let's not even get to cancer, telling people with colitis that it doesn't matter what they eat. The burden of proof is constantly on this side.
Uh-huh.
And it's interesting.
Yeah. No, it is interesting. Devil's advocate.
Yeah, do it.
I still need to, be able to differentiate that the medical advice, even in the same space for the same patient, is going to be different from you than from me. Yes. So how do we differentiate that without making one more important than the other, or making one more valid than the other? Yeah.
So I think if we approached it on, listen, it's not going to happen. So this is just like, we're talking.
Right. You never know.
In La La Land. Like it's not happening. We're not fixing it.
No, I'm fixing it. I'm going to work on it. It's on my list.
Question is good to expand our horizons. So I want to make sure that no one thinks I'm like, oh, we should do this, because it's not happening. And I still practice conventional medicine every Monday. Right. So, but I imagine if we understood from the get-go that everyone's somewhere on the spectrum. Mm-hmm. Of wellness to illness. Mm-hmm. And you would say, welcome to this part of the spectrum. I'm here for you now. And then when you're post-treatment, pre-treatment, I want you to see my colleague here and there. Like, I think that would be, instead of like this and that, or understanding that there's tools for depending where you are on the illness wellness spectrum.
Sure.
I think that would be awesome. Not going to happen, but I think it'd be awesome.
I also think, though, it's a little more delineated with a cancer diagnosis, for example, if the patient's going on chemotherapy, because there's a before and then there's an after. Whereas with a lot of the chronic conditions that people are being treated for, diabetes, hypertension, what have you, it's an ongoing treatment with conventional medicines, right? But then there's mechanisms by which I'm sure you could educate us on how you could help the patient improve and become healthier, and then not even need those medicines, for example.
Absolutely. But I would say that in your delineation of before and after chemo, I think there's a during also. I think that if you're provided with a support, right, I think there's going to be different outcomes. Someone who's undergoing chemo,
Yeah.
who's
Yeah.
eating sugar and Dunkin' Donuts every single day,
Right.
versus someone who's also doing other things and
Good
red
point.
light therapy and all things. So I think there's also that, and studies have shown also like reduced neuropathy, and right, there's a lot of reduction
Sure.
in side effects if it's used adjunctively with a treatment.
That's great. Actually, I love that. It's a very important point. And I think the problem from my side of the table is that I don't know enough necessarily about the adjunctive things that are being done by the functional doctor to know that it's not going to interfere with my chemotherapy or the treatment that I'm providing, because my end goal is to make sure that I've killed all of those cancer cells. So then I guess it becomes a fear factor almost on our side. Like, well, you know what? You don't do anything else right now because I don't know if it's going to interfere, right? And that's the
a
problem.
really good and excellently vulnerable point, and I'm so glad that you were honest enough to say that. And that's something I didn't consider. So thank you. This is why I love talking to women.
Yes.
Thank you for doing that. The fear factor, and I noticed that a lot with like pre-op. Just stop taking all these supplements because we don't know what to do, right?
Yeah. Yes. Don't take anything.
Yeah. Or pregnant women, just stop taking everything because we don't know where like, but multivitamin, it's okay, but any other supplement is not okay. So you're right. Once again, because of a lack of a conversation, how cool would it be? Let's just say if you and I work together, multiply by many, where we could come up with protocols together. And I think some people are doing that. But just at its basic, functional medicine or any type of root cause medicine, let's just really talk basic. It's going to be about nutrition. So what in nutrition could probably mess up your chemo?
No, none. Right? I think it's more the more extreme. So like if I know that a patient's going to get intravenous vitamin C on a weekly basis and she's getting a chemotherapy that, for example, adriamycin, that requires oxidative species to be present to kill the cancer cells, and the patient's taking mega doses of vitamin C intravenously or even orally, is that counteracting the effect?
That's a great point. A vitamin C, because there's so much rhetoric around it being anti-cancer.
Oh, 100%.
Right. And so then your concern is it interacting? Yeah. So, but it's so interesting you brought that up. I think it would be so much better if you had those 5 or 6 things that you could say, please don't do these 5 or 6 things, but I truly support the others, or have the conversation, because then otherwise patients will still do it and hide it from you. Not you.
Oh, I know. No, I know.
Yeah. And I think anyone who's already coming to you, right? Because there is a segment of the population that absolutely will not do any treatment. I don't think we're talking about that population. The population has already come to you, has made a decision. They're jumping into allopathic medicine.
You don't know that. I mean, honestly, I've had many patients come in listening, already kind of deciding that they weren't going to do the treatment and they were going to go alternative methods, which may or may not include nutrition. It could mean a trip to Mexico, and I don't even know what they do there. But so I've had some very challenging conversations with patients, and it breaks my heart, because it really, I try to tell them that I support additional things to help provide your wellness and promote your wellness, but not in place of what I need to do.
Right. I'm sorry, I meant those were in chemo, but I could see that in that consultation period that not everyone's ready to do that.
No.
It's a really hard call. It's a really hard call. You know why? It's a hard call because there's so much distrust of the system. I just wrote an op-ed around vaccines, and I'm not an anti-vaxxer, so we're not don't worry, we're not going down that rabbit hole.
I wasn't going to touch it anyway.
But I am I'm also not a pro-vaxxer. Okay. I don't like this binary, and I'm bringing this up for a reason.
Sure.
I don't like this binary because there are 100% people who are affected, children who are affected, and we are not recognizing it as an institution. We close our eyes to it. We are of this mindset that either, if you're not hemorrhaging out of your ear secondary to a flu shot, then anything else is imagined. Okay. Any other side effect that you have is imagined. And it's not true. I've seen children regress. I've seen adults regress. I've seen brain fog that doesn't go away. I've seen without question. And we know around COVID that blood clots and all things, but we have this, stance that anyone who's complaining about it is crazy. And so what that's done is the people who are in the middle, who are hesitant, have nowhere to go but into the anti-camp. So this lack of transparency from this lack of fluidity, this lack of understanding that some things are an N of one.
Right.
Right. I get that your study says that the flu vaccine is safe, but I'm telling you what happened to my kid after he got the flu, and you have to believe me, and you can't call me crazy. And so the part of the problem is, and I think, you're very open-minded, but I think a lot of people experience oncology where it's like, it's my way or the highway, sis. And so in that case, I'm going to go the other way, because if I can't have an open, honest conversation with you about what I can and can't do, I'd rather go to Mexico or whatever it is.
Right.
And so I think people are in the conventional world are really scared of having conversations.
Yeah. I think probably because we don't have the answers, right? So if I agree with you that in certain people, children, that the vaccine will cause
harm,
right? But I can't pick out from the crowd who it's going to harm.
There we go.
We look at the field effect, right? And so we decide that, well, we're going to lose a couple, but we're going to protect the masses from the flu.
Right. Which is a really great concept if you're only dealing with health policy. But if it's your kid.
Right. Oh, yeah.
Right.
Right.
And so it's the lack of this dogmatism is what's causing the extremism.
Right.
Like my iPad was something entitled, like, if you want vaccine hesitancy to go away, we have to recognize that side effects exist. Like anything else, once you shine light on something,
right.
It's easier to manage. Anyway, I know I kind of got off topic, but.
No, but it's very interesting. And I think it actually has a lot of applicability to so many things that are going wrong in medicine right now because of the fact that we are so dogmatic about certain things. And how about the menopause and HRT conversation, right? Oh my God.
Okay, that's a classic one. That is so classic. How many years? And still to this day, I am convincing every woman. How many years did we spend telling women that they're fine and that hormones are dangerous? How many years?
Right.
Yeah.
But even at the next level, there's also a lot going on about who can take it and who can't. And, there's some people that are on social media saying, well, it doesn't matter if you had breast cancer. It doesn't matter. Everybody can take it. Estrogen doesn't cause breast cancer, what have you. I'm not going into the whole debate. I'm just pointing out the fact that we are basing all of this on studies from over 25 years ago that are not even necessarily relevant. And just like the vaccine situation, where I can't pick out of the crowd which kid is going to have a bad effect from it, I also cannot necessarily pick out everyone that's going to get cancer because of going on hormone therapy, because there will be some. To say that it doesn't cause it at all, it doesn't actually make sense. And I think it's going to lie in both scenarios in the DNA, right? And so something that I'm really become very interested in, I don't know if you've been looking into any of this, is functional genomics. I think is so interesting. So the person that metabolizes estrogen down one pathway versus another pathway, and you're feeding them extra estrogen, or they're estrogen dominant, for example, they are at more risk probably if their estrogen is being metabolized down the bad pathway, right? They're more at risk for breast cancer.
So I love that you are mentioning this, but you just also showed that studies are being done, but not allopathically necessarily, right?
Right.
And so if you want to eliminate the field effect of, I can't tell which child is going to get this or which woman is going to get that, we have to decide that it's a problem, and then we have to put resources to it, because clearly some studies have already been done. They just haven't been done at scale. We know why. There's no question, right? We do know why they haven't been done at scale, right? Why? Because there's no pharma attached to it. I'm not anti-pharma, but pharma is the one sponsoring. So if there's, and they need to make their money back, I'm not even going into that. And so if there's no product at the end, study's not getting done. But what would it look like if we studied?
Especially since they shut down the NIH and we can't get grants from there anymore anyway. But so
Don't
You know,
start this.
but the thing is that there should be companies out there, and I would love, if anybody's listening, please call me. I would love to talk to a company that can look at, you know, their data. We have DNA tests that we can utilize to tell a patient whether or not she needs chemo, right? Oncotype. We
Right,
have
because there's a
DNA.
product at the end.
Right, but there should be a product for this as well. So, and then, you know, we have other tests, BCI it's called, breast cancer index, which will help tell whether or not the patient needs to stay on the treatment for the oral hormone therapy for 10 years or 5 years.
Product.
And product, exactly. So let's get a product.
But there is no product.
Call me.
But when
No.
we talk about estrogen therapy, we know it's compounded. There's not really, pharma's not truly involved in it. They don't really need to be, which is why they're against, you know, compounding. And so the data is not forthcoming. Dr. Bredesen, who's like the godfather of Alzheimer's, was on my podcast twice. And he, you know, so data driven, and he actually reverses Alzheimer's, right? Depending on how far gone they are, it will depend how well they do. But he does it through many variables. But because there are so many variables, he has never been able to get funding for a study because the study needs one variable. He's like, it's not one variable. It's not just take this pill. It's you have to sleep and your hormones have to be okay. And you have to be, you know, in ketosis and this and this and this. And it makes a study impossible. But then he says, I challenge any neurologist in the country to put into one room how many people they've improved Alzheimer's, and I'll bring all the people that I have, and we'll see that, right? So is this actually live? That's so cool.
I'm not sure. It is live some places. We did?
We did.
Well, but it doesn't look like it's
to
going
pay for
on
DNA testing. We're live. That's exciting. Okay.
Wait, which
Janice McKella and LinkedIn.
Oh, and LinkedIn. Okay, LinkedIn. Yeah, it doesn't look like it went through to Instagram, unfortunately. That's tricky to get that to go. But at any rate, we're on Facebook, Instagram, and TikTok. So
yeah, we run into the problem with cannabis. The hard part is getting insurance to pay for DNA tests. Yeah, I mean, the hard part is getting insurance to pay for all of this.
Right.
And it never will, right? We understand how insurance works. Insurance inherently works on diagnosis coding, procedure coding. And so the absence of diagnosis or the absence of procedure can never result in reimbursement.
Right.
So getting insurance to pay for anything is difficult, but our patients should not confuse whether or not something insurance pays for as to whether or not it's valid.
Right. Oh, absolutely. Absolutely.
Yeah.
So let me get back to a couple of questions.
Yeah, sorry. Let's get back on track. I'm sorry.
Listen, I want to go out to lunch with you. I mean, you and I could talk all day. So talk to me a little bit about root causes, root causes of chronic disease, brain fog, you know, even cancer, so to speak.
Even cancer,
yeah.
First of all, I would say that anytime, going back to genetics to answer this question, we have epigenetics, right? So we know we have genes. There are some genes that are, just for our audience, some genes that are brown eye, blue eye. It is what it is. And there's some genes that turn on with environment, including cancer genes.
Right.
So just on the macro level, before we go into root cause, if you are feeling unwell consistently, and that means there is something in your world that is making you feel unwell, it stands to reason that consistent inflammation will toggle on any underlying kind of waiting diseases, including cancer.
Right. Can I interject though for our audience just to clarify that? So epigenetics means that there's a change to the DNA within the cell that's caused by something in the environment, essentially. Yeah. And so there are molecular or changes or groups that are stuck on the DNA that changes how that gene functions. So that's epigenetics. Yeah. Okay, sorry.
No, it's great they did it. So let's give like a really simple example that everyone knows. Everyone knows that, broadly speaking, if you don't smoke, broadly speaking, you're not going to get lung cancer, right? We know there's exceptions. No. I'm broadly speaking for the layperson. Okay. For the layperson. Okay. The layperson understands that if they smoke, they're increasing the risk of lung cancer. Let me say it that way.
Okay.
The layperson understands that in the environment, if exposed to smoke, that's why we don't do secondhand smoke. That's why we've changed restaurants. The layperson understands that in certain environment, they were not born with lung cancer. They smoked or they were exposed and now they got it. There's understanding that exposure to something gives us lung cancer. I saw your face, so I quickly fixed myself to make sure that this is why we're on point for the layperson.
Right? I can turn this off.
So there's this understanding. I want to bring it to that level. Be like, oh yeah, of course, if I smoke, that's
Right.
increased. That's why we tell people not to smoke.
Right.
So why does it end there? There are so many things that you could be exposed to that could turn on disease and cancer.
Right.
So I just wanted to connect it to that because
Yeah.
when people attach it to something that they already know.
Right.
So first and foremost, let's go to the super basics. Sleep. If you are not sleeping, if you are believing that you have to wake up 4 a.m. to go to the gym, if you are believing that you can stay up all night and do your emails, or you are not going to be okay. You are not going to be okay. Lack of sleep has been shown to be causative, not correlative to dementia, right? So lack of sleep. So you don't get dementia overnight. You have brain fog, and it comes and goes, and it comes and goes, and it comes and goes, and then eventually it takes longer to recover. Sleep is part of that. Nutrition. You cannot possibly eat food that you cannot make in your kitchen. It is a lab experiment. You cannot wake up in the morning, drink a drink that's a lab experiment, get a food that's a lab experiment, lunch that's like, and expect to feel optimal. So nutrition is part of it. We know that food is code. Broccoli has a code. Part of that is also, right, to help detoxify estrogens, among other things. So everything has a code. So which code are you putting into your mouth? So we have lack of sleep, we have nutrition. And the other thing is also, just for the basics, are you going to the bathroom? Are you constipated all the time? Are you releasing things? Are you drinking water all the time? Right?
My patients are listening. That's like one of my everyday questions. How's your poop?
Yeah, if you're not getting it out, like it's a mess, right? So those are the basics.
Right.
But then environmentally, I would have to say that's something that's really, really overlooked in conventional medicine is mold exposure. Mold exposure is insane. And how it affects people is insane. And 5 years ago, me would listen to this woman and be like, are you crazy? Are you wearing a tinfoil hat? But this is, I swear to God, I have moments when I'm like, are you okay? So I want to know for any of my conventional medicine colleagues who are like, oh, eye rolling, now we lost her, she's crazy. I want you to know I used to feel the same way until I saw it in my patients. So if you have not experienced this clinically, please don't eye roll. Please have the humility to know that you may not have known about it.
You don't know what you don't know.
You don't know what you don't know.
Can I just interrupt though?
Yeah.
Because as soon as you say something like that, I mean, I know how much I sleep. I'm not sleeping enough. I know that sometimes I can't name all the things on the ingredient panel of something I'm eating. I get that. But this mold thing freaks me out because I don't know where it is. How do you test for it? How do you know if it's here? And how do you know if you have it?
Okay, great question. Excellent question. Yeah. So listen, almost all of us are exposed to mold. There's mold everywhere. And not everyone who is exposed to mold is unwell, right? You can have an entire family. You can have, I've treated a police officer, everyone's fine in her precinct, whatever it's called, but she cannot go in there. So
she can't detox it.
She cannot detox it. Right. So we don't all have to like go redo our homes. If you're feeling fine, leave it alone. And most of the time you don't see it. So how do you know? I would say this, if you're feeling unwell and there's like a list of symptoms, but let's just go classically brain fog, sometimes air hunger. People have POTS. People just have like really these unexplained, I'm going to say subtle, but not so subtle because it affects their life. Focus. And especially if you've realized that it happens in certain areas, like, man, when I get home, I'm like this. When I'm at work, maybe you think it's your stress at work.
Right.
And you've done everything. You have to do, mold has to be your last diagnosis. You have to go everywhere first. You have to go to your primary, your endocrine, your GYN, get the scans, like never skip those steps ever.
Right.
When everyone scratches their head and you've cleaned up your diet, like don't come to me and you're still eating McDonald's. You've cleaned up your diet.
Chicken McNuggets are not a whole food.
Chicken McNuggets are a whole bunch of something. So once you've done all that and you're still, that's when you start considering that it's this underlying thing. And then there's tests. So the first thing you do is you test your urine. And then if it's positive, you test your home. And then you make sure, and you see if it matches. And it's a procedure, but it's a process to get rid of it.
And how do you test your home? I rip down walls. What am I doing?
Sometimes there's companies that can come do it, but you could first start, you can get these little kits, you swab the areas that you're concerned about, you send it out like little Petri dishes, it grows and they come back with a report. If that is the case, it's a problem because you have to remediate your home because otherwise you're right, you're stuck in the loop, and then you have to detoxify. But now we're talking about this chronic inflammation. So let's just say we have the person who's eating not great. They're working from home in their basement. They're around mold all the time. They're brain foggy. They're not feeling well. They have anxiety. They have depression. They have everything.
All the things.
Why would it be surprising that now they also have cancer? Right. So I'm not saying mold causes cancer in this direct 1 to 2, but I'm saying if you're one big hot inflammatory mess.
Right. It's the inflammation and all the things that contribute to the inflammation.
And we don't take all those things away, we're going to end up with it, unwell. Yeah. I want to make sure no one says Dr. E said mold causes cancer, because it's not that linear.
It's not that simple.
Not that simple.
Not that simple. Nothing is that simple, of course.
Nothing that simple, yeah. And then there's other underlying infections, like Lyme is another one.
Mm-hmm.
So yeah, lifestyle and underlying infections are root causes.
Mm-hmm. So say I had a cancer patient and she wasn't feeling well up until her diagnosis, and she wanted to work with somebody who would look at some of these root causes with her. Where would I find somebody to do that?
A really good resource, I would say, is Institute of Functional Medicine. Mm-hmm. And the reason I like that as a resource is because you have to be a clinician first. Mm-hmm. So they do have a health coaching section, but that's like coaches, and God bless coaches. They're amazing. But I do have a slant towards someone who immersed themselves first and then went back to school for more, because you have a very different layer.
Yeah.
And so you have to be an MD, DO, PA, NP to be allowed to be certified. The certification is pretty rigorous.
Yes. I've looked at it. It's
rigorous.
I mean, I'd have to take a year off and just do that.
Yes,
probably.
It's really intensive. I'm certified there. It was really intense. So that's a good resource. At least you have potentially someone. And then, you look through your list, and then you kind of see everyone has like their thing that they're more comfortable with.
Sure.
Yeah.
Sure.
Does that help?
Yeah, Institute of Functional Medicine. I'll put it in the show notes.
Yeah, okay.
Right, so people can look at it if they want to. You're not in there? Why aren't you in there?
No, I'm there. I'm saying I'm not. I don't get a kickback for it. I'm not affiliated, like in that respect.
No, I don't either. Although there's a really interesting course this weekend, so maybe they can give me a discount because I just gave them a nice nod.
Yes,
I'm just kidding. Anyway, so on to our other question. So tell me about gaslighting. That's always a fun question, right? Especially for women, gaslighting with menopause symptoms. What does that mean to you?
So gaslighting, first, what does it mean to the patients? It's this experience that your feelings were unheard or dismissed in a medical setting. It's a bit of a misnomer because gaslighting, originally the psychological term, had a purposeful manipulation around it. I don't think that most clinicians are purposefully gaslighting. I consider myself a recovering gaslighter. I do.
Do you have to go to meetings for that?
Yeah, I do have to go. These are one of my meetings. I have to wear the scarlet letter and talk about it every time. And as a recovering medical gaslighter, I could say to you that with the exceptions of a few a-holes who are just a-holes in their entire lives, those are very few, most clinicians are not aware that they're gaslighting.
Sure.
And that's an important distinction. So medical gaslighting is that feeling. So again, I'm removing the ones that are just shouldn't even be serving coffee, let alone practicing medicine. So let's eliminate those people because they're just not nice. So let's not talk about them. But if you're like, when you go to school, this is what I need my patients to understand. When you go to school and you learn this thing, and you learn that this is how you ask the questions, this is what the old cards, this is how you get a document. Nothing else is relevant. When did the symptoms start? Who's talking about your gestational history? Like, there is an indoctrination that happens and a fervor that if you come to me, I will use every tool that I have to try to figure out what's going on with you, Mrs. Smith. I really, really will. And I do it with all my heart. But if all of my tools tell me, Mrs. Smith, there is nothing wrong with you, I am not saying it to gaslight you. I'm saying it because my tools found nothing wrong with you.
Right.
My MRIs are clean, my scans are clean, your labs are normal. I have to conclude there's nothing wrong with you. And that's not from malice, and it's not from greed. It's from indoctrination.
Right. I would say I can't find anything wrong. Doesn't mean that there isn't.
Clinician.
Right. Well, I'm allowed to serve coffee too. No, but I would say I can't find anything wrong. Let's find somebody else. Let's get some other opinions in here.
Yeah. But you're also an oncologist, so
right.
To say like I haven't found cancer.
Right.
So by definition, you're going to be like, well, let's go somewhere else, rheumatology or whatever. But in internal medicine, family medicine, right, it's a little bit more nuanced. And so there's a lot of time of like, I can't find anything. Maybe you're just anxious. Maybe you're depressed. And so I just want to impress upon a listener, first and foremost, it's really not malicious. It feels malicious.
Yeah. Yeah.
But it's really from a place of they don't know better. But they are doing it. No one goes to school all this time, graduates, opens up a practice just to sit down to just be mean to you.
To be a jerk. Right.
Yeah, except for those coffee people.
Right.
They really think that. So knowing that is part one. But part two is like, and the way to understand that is, if this was your home, if your toilet bowl was leaking and you see it leaking and you call the carpenter and the carpenter is like, I tried all my tools, my hammer, my nail, and he says to you, my conclusion is that your toilet is not leaking. You would laugh. You'd be like, I called the wrong guy. I should have called a plumber.
Right.
You wouldn't feel gaslit.
Right.
But that's exactly what's happening. When they say nothing's wrong with you, it's like, I got you, boo. It's just your tool set. You're a carpenter. I have no problem. And so now the minute you realize that the emotional feeling of like, I can't believe that it's their limitation. It's the doctor's limitation. So for the patients listening, when they tell you you're fine, amazing. Thank you so much. All that means is that their tools can solve it. Don't take it personally. Move on to the next.
Right.
Right. So that's that. So just reducing the emotions around that feeling of medical gaslighting is so important. And then I ask our patients, our mutual listeners, you have the skill set. You know how to plan a wedding. You know how to advocate for your child. You know how to run a business. You have the skill set. You walk into the medical office and all goes out the window. Like you get lost. There is this like, and I'm not saying to go in and be loud or to be rude. I'm just saying understand.
Yep.
And when they say there's nothing, okay, thank you so much. And treat it just like the carpenter. It will be a completely different experience.
I love that analogy. In fact, I use that quite a lot. And I think you and I are very akin to empowering our patients, and that education as well as understanding where the doctor's coming from, I think really helps a lot, because, if the patient always feels that the doctor isn't hearing them, you either have to find another doctor or you have to find another way to communicate with them. Right. And so I try to teach my patients exactly how to best communicate with their doctors. And sometimes they need more information. Maybe you're not being clear on exactly what the symptom is. But let's think about the menopause symptoms, though, right? So women for perimenopausal were for so many years being gaslit that they were crazy, right? But really they had perimenopause and estrogen deficiency. And again, it wasn't coming from malice. It was probably coming from lack of understanding, right?
And fear. Yeah. Absolutely. That study did a lot of damage.
Yeah.
Yeah. And so this goes back to like at its core, sometimes I speak to other nurse practitioners, like I teach a little bit about functional medicine in medical settings. And what I say is ultimately, I'm not asking you, dear clinician, to go and learn all this. Not everyone's crazy to do this, certification. Right. I'm asking you just to be open to the space and to be able, what a different experience for the patient to say, and I believe you. I just have no idea how to manage it.
I know. That's hard to admit. I mean, there's a lot of ego, right?
A lot of ego.
There's a lot of ego out there to admit that I can't fix this. I don't know how to fix this.
Just telling a patient, I believe you, is so therapeutic. You're already 90% there.
Yeah.
It's so empowering to feel it. Because that's what when I used to do consultations in functional medicine, just me telling them, believe me, I would inevitably there be crying just to be like, finally someone believes me. And I'm like, I'm so sorry, for 20 years, no one even believed you.
Yep.
That's the hard part.
Yeah, that's true. No, that's a really good point. And so any clinicians that are out there, just sometimes you just have to give some validation to the patient's symptoms and don't act like.
Even if you think their things are off the wall, it's because they're searching. Right. They're searching. And just, they need assistance.
You know what I always found difficult? I know we've kind of run over time, but what I always found you don't care? Okay, we'll just keep talking. All right.
Yeah.
Well, I'll order pizza. Oh no, we can't. Is pizza a whole food?
It's something. It's like Friday afternoon. Friday afternoon, you could eat pizza.
Wait, but dough is flour, right?
You're not really being serious. You actually, no, you seriously asking me if that's a whole food?
No, I know it's not a whole food. It's not an apple, like, but it's
So
made
is
of whole
flour.
foods. You know, not to have flour
You're
either.
making it yourself, and yeah, I guess flour, but there's no protein in it. Are we? Should we macro this? There's no protein.
Oh shit!
It's
I
heavy on the
love
gluten.
pizza. So how can I make pizza healthy? This isn't where I was going, but listen, I'm Italian. I need tomato sauce. I need mozzarella.
You know that every single nationality will say the same thing. They'll be like, I'm Hispanic. I need my rice. I'm this. And so everyone says
I
that.
didn't say pasta. I said tomato sauce.
Yeah,
In fact, a good sauce I'll eat right out of the jar.
Sauce
Or
is
the pot.
not necessarily bad unless you're, tomatoes bound. How do you make pizza healthy? It's a great question because it depends on what your goals are. If you're gluten-free, you have to be gluten-free. If you're dairy-free, you have to be dairy-free. At the very least, we should throw a little bit of chicken on it so we can have some protein.
All right.
So it really depends on the goal, and that's important. That's why I answered it that way, because that shouldn't be prescriptive either. That should be nuanced.
Right.
Well. Yeah.
I'm just saying that pizza in general is not like, when you take a frozen food from Costco that has 75 ingredients in it.
Yeah,
right.
I agree.
I mean, that's different, right? I mean, I can name the whole foods that go on a pizza.
You could make a pizza.
You can make a pizza with Whole Foods.
Anyway,
I digress. So anyway, what was I even going with that? Anyway, so the thing that I always found really difficult in clinic.
This is the best podcast ever.
The thing I always found very difficult in clinic was that not that the patient had a symptom that I couldn't understand, but a lot of times patients will come in with a symptom and their theory as to why it's happening. And a lot of times those theories are either off the wall or I can't make clinical sense of it. And that's hard. That's harder than just a patient coming in and be like, my right shoulder hurts. And I say, I can't find any reason. Let's send you to see a physiatrist or something. If a patient comes in and says, my nose keeps running and I think it's because my neighbor has, pigs in his backyard or whatever. And you're like, well, maybe,
Yeah, you're right. Sometimes some of the theories
so sometimes you're dealing with not just the symptom, but also their theory that goes along with it. And so I often will educate my patients to make sure that not to provide theories, because you don't necessarily even want to jade your physician unless they're completely off base on it. I would rather just know what the symptom is and then let me come up with the differential. And if you think I'm off base, then you can interject some of your thoughts. I like that. But I feel like if you go in and you lead with, there's pigs flying through my backyard and that's why my nose runs, the doctor's going to almost dismiss the symptom as well as your theory, right?
Yeah. So I guess the my answer to this would be, I guess it depends who I'm coaching, right? If I'm coaching the patient, then yes, unfortunately, I would suggest to you, as you did, let's tailor your story in such a way so that they will be ever listening. If I was coaching a clinician, I would say, part of this therapeutic encounter is for you to help them prove or disprove this, because there's an anxiety around this. And that's a health issue also, right? So there's an anxiety around their neighbors. So then let's figure it out, right? There's so maybe can you go home and track it? Does it only happen when it's here? Was that maybe they really are allergic to this, or maybe it's something else, right? And so, or maybe you'll surface that they're just their neighbors like screaming at them all the time. So, as clinicians, that's part of our job.
Absolutely. You have to kind of
and you have
piece through it. Like, okay, let's take this symptom.
And let's put pigs on the list as a possibility.
Flying pigs,
of course. And then let's also put mine and let's together kind of rule them out and see where we go.
Yep.
So yeah.
Great. All right. Before we digress anymore, what other things would you like our audience to hear from you today? It's Friday.
I would say to you,
yes,
if this was your child, you would know what to do. If this was your child who, says to you something's happening in school, and you go to the principal and the principal says, no, I know Mrs. Cohen for a really long time. There's no way this is happening. And you're like, listen, I don't know what to tell you. My son is telling me this. You would not leave the principal's office. You go to the other I'm not saying to be mean about it, but you would not stop whatever it is to advocate, if medical, not medical, for your child. You would never stop. respectfully and appropriately, but you would never stop.
Right.
Treat yourself that way too. Don't stop. If you feel that that's not the right diagnosis, if you feel that you're, unheard, just keep going. That doesn't mean keep going to the same doctor with more.
Right.
You've already exhausted that.
It's like pounding a dead.
Yes. Keep going, but believe
Right.
that inner voice that tells you, I still think something's wrong. Believe it until it's full. And just because as women, especially, we're like, all right, maybe I'm crazy. Maybe I could take things out of it.
Right.
So do it for yourself as if you would do for your child.
And put you first.
And put you
gotta
first.
always put yourself first.
Yes.
All right. Well, with this, I'm going to sign off. I cannot wait to have another conversation with you. You don't live far from me. I'm telling you, we need to have lunch. We could have a really fun conversation. And I'd love to meet your wife.
Oh my God.
What kind of clinician is she? You said she's in medicine.
Physician assistant. We met in the emergency room, and she just teaches medicine now.
Awesome. Yeah. Awesome. So cool. Listen, always a pleasure. I love watching your content. I'm so honored that you came on here. What a great conversation. I love it when I get these VIP things. I'm like, I ask a question, like, oh, I'm sorry, you're not a VIP. I can't tell you that.
I answer, by the way.
Oh, is that what?
I don't answer anyone because my team answers, but I see your name and I'm like, I got to answer my girl.
I love the snark. It's the best. All right. Goodbye, everyone. Have a wonderful weekend. And thank you again.
Thank you for having me. Bye.